Hi there, I'm Jordan Mast, PA at the Colorado Neurological Clinic here in Denver, back to talk to you all today about blood-based biomarkers for Alzheimer's disease. We know that early diagnosis is very important from a treatment perspective, but it's also really important because timely education, referrals, and support services are absolutely critical. Blood-based biomarkers, or BBMs for short, are becoming more readily available, and knowing which ones to order and for whom can change the trajectory of these patients. So let's start by talking about who should receive these blood tests and who should not. We typically do in-office cognitive assessments for anyone expressing concern, and regular assessments are generally covered by Medicare for patients 65 and older. According to the Alzheimer's Association guidelines, BBM screening is recommended for anyone who has measurable, objective, cognitive impairment, such as MCI or dementia, or other verifiable symptoms of cognitive decline. Our standard screening tools, such as 88, Minicog, and MoCA, can be used to identify signs of cognitive decline. Before using BBMs, we should also complete a comprehensive medical evaluation, including neurologic and psychiatric assessments, laboratory testing. This step is incredibly important because, as I discussed in my last video, sometimes patients can beat the test when it comes to these screening tools. But these examinations and patient history can still give us an objective information that makes it appropriate to use BBM testing. There are some for whom BBM testing is not recommended. If patients perform as expected in preliminary cognitive assessments, these blood tests may not be yet appropriate. This may change in the future as our understanding of Alzheimer's disease expands. It also may not be appropriate for patients experiencing obvious, modifiable, or temporary conditions that can account for their impairment, including certain medications. That being said, even patients that have these conditions could also be experiencing signs of early Alzheimer's disease. These tests can be ordered by neurology or a memory care clinic after referral, but they're starting to become much more common in primary care as well, especially as providers are becoming more and more familiar with how to interpret these tests and communicate the results to the patients. Guidelines don't currently endorse any specific tests yet, but do note that when we're ordering these tests, we should consider whether looking to triage or rule out AD with relatively high probability, or on the other side of the coin, gain confirmation, meaning rule in AD with high probability. When triaging to determine the presence or absence of Alzheimer's disease pathology, we're looking for tests with high sensitivity of at least 90% and a specificity of at least 75%. But if we're looking for confirmatory testing, we want both the sensitivity and the specificity to be at least 90%. There are two specific markers that are generally used in biomarker testing: amyloid beta and p-tau. The A-beta 42/40 ratio test measures the ratio of two forms of amyloid beta protein, with a lower ratio associated with Alzheimer's disease pathology due to the accumulation of amyloid beta plaques in the brain. P-tau assays measure different p-tau analytes, and elevated levels are strongly associated with Alzheimer's disease dementia as well as other forms of dementia as well. p-tau 217 is considered to be the most reliable blood-based biomarker for detecting evidence of Alzheimer's pathology, but p-tau 181 and 231 are also used. In our clinic, we rely mostly on p-tau 217. There are currently two US FDA-cleared BBM tests for Alzheimer's disease. One uses a p-tau 217 amyloid beta plasma ratio, and the other is a p-tau 181 plasma test. Both of these have shown to have greater than or equal to 90% sensitivity and specificity, and can be used for the early detection of amyloid plaques in association with Alzheimer's disease in patients aged 55 and older, exhibiting signs and symptoms of the disease. Diagnostic accuracy estimates across available BBM tests are highly variable, and many commercially available tests don't meet these accuracy thresholds for sensitivity and specificity. This is especially true for testing that rely on single cutoff values. Newer testing paradigms implement a two cutoff approach, meaning patients are classified as negative or low, intermediate, also known as uncertain, and positive or high, with these intermediate values potentially triggering further analysis by amyloid PET or CSF analysis. Though some recommendations suggest that BBM testing with high degrees of certainty is enough to recommend treatment, many practices, including our own, still recommend doing amyloid PET or CSF analysis as confirmation. As accurate blood testing becomes more readily available, amyloid PET scans and CSF analysis may become less necessary over time. This leads us to our next video, where we'll discuss the importance of considering all of the results a patient may have related to brain health and how to interpret them together. See you there.